Good morning. So today we'll be talking about palliative sedation. My name is Seema Varma. I am a hospice medical director and palliative care physician at Barnabas Medical Group and VNA Health Group. I'm also a hematology oncology physician. So we have all faced in our practice that patient or family who have had enough. They just cannot continue like this anymore. They want it to end, or they need help to relieve their suffering. So the most available tool for physicians or practitioners today, ethically and legally, is palliative sedation, where we can help families or patients somewhat to relieve the suffering. So we'll be covering certain aspects of palliative sedation today. What's the definition of palliative sedation? Ethical considerations in palliative sedation, definition of refractory symptoms, indications for palliative sedation, how is palliative sedation different from physician-assisted suicide and euthanasia? And what are the certain medications we can use for palliative sedation? So palliative sedation is the deliberate administration of medications to reduce the level of consciousness in patients with refractory symptoms who are at end of life. The goal is to relieve suffering, and intent is not to hasten death at the same time. Our goal is essentially to relieve suffering. So in keeping in line with that, the level of sedation is proportionate to the patient's level of distress. Alertness needs to be preserved as much as possible. So we try to use the lowest possible doses to relieve the suffering without affecting patient's consciousness. At times, the administration of sedatives to the point of unconsciousness becomes necessary when less extreme sedation has not achieved the relief of distressing symptoms. Approach of sedation to unconsciousness is only for the most severe intractable suffering when death is imminent and patient is at end of life. So levels of sedation can be mild, intermediate, or sedation to unconsciousness. Mild sedation, patient remains awake with a lower level of consciousness. It's usually aimed at relieving the distress. With intermediate sedation, the patient is asleep, but able to arouse or awaken to communicate briefly with family. And when mild and intermediate sedation do not relieve symptoms or cause or distress, then sedation to unconsciousness may be necessary. So palliative sedation is not well studied in the palliative care literature. From the data that we have, palliative sedation is currently being used in about a third of patients at end of life in hospice and palliative care setting. Palliative sedation is also known as terminal sedation, end of life sedation, total sedation, sedation for intractable symptoms at end of life, continuous sedation, prolonged sedation, controlled sedation, or SIDD, which is an acronym for sedation for intractable distress in the dying patient. Palliative sedation has not been universally and definitively defined yet. Most clinicians would agree that there are variable degrees and durations of sedation. So what are the ethical considerations of palliative sedation? Palliative sedation ethics are based on three principles: autonomy, beneficence, and the doctrine of double effect. Autonomy is the person's right to make their own healthcare decisions, or surrogates can make the decisions based on patients' personal values, beliefs, and goals. Beneficence is where we, as clinicians, want to provide the care that will benefit the patient and promote the well-being for the patient, to provide relief of distress and promote their well-being. And the doctrine of double effect and its four conditions need to be met. So doctrine of double effect states that if doing something good has a bad result, it's ethically okay to do it, providing that the bad result was not intended. The four conditions of this doctrine are: first, the moral intent has to be the good effect. The moral intent guides the ethical validity of this doctrine. The second condition is that the bad result is not directly intended, and if the bad result is known and foreseen, it must be tolerated and permitted. Third, good results should not be a direct causal effect of the bad result. And lastly, the good result needs to exceed or balance the bad result. So as long as the four conditions of this doctrine of double effect are met, it is ethically okay to do the act. So the clinician's intent has to be to relieve suffering, not to hasten death. The degree of sedation needs to be appropriate to the severity of suffering and symptoms. The patient needs to give an informed consent. If the patient is not capable of making their own decisions, surrogate decision makers should give informed consent consistent with the goals of care and values previously stated by the patient. Withdrawal or withholding of life-sustaining treatment is a separate discussion that needs a separate consent. For example, if the patient is on NG tube feeds or TPN or on a ventilator, withdrawal of those life-sustaining treatments needs to be a separate discussion prior to initiating palliative sedation and needs a separate consent. So what are refractory symptoms? Refractory symptoms are symptoms that have not responded to standard palliative care measures. The most common refractory symptoms we see in practice are pain, delirium, agitation, dyspnea, nausea, vomiting, uncontrolled bleeding, myoclonus, and uncontrolled seizures. The physician must also perceive that any further invasive or non-invasive interventions are incapable of providing additional relief or adequate relief at this point, and may be associated, these interventions could be associated with excessive morbidity. So literature reviews have shown that even with the highest standard of care and attempts at symptom palliation, about a third of patients receiving palliative care in hospice programs experience severe refractory intractable symptoms at end of life. And that is in line with our previous data stating that about a third of the patients in hospice and palliative care programs receive palliative sedation. So the indications for palliative sedation are refractory symptoms. Palliative sedation to unconsciousness is only appropriate in terminally ill patients as an intervention of last resort. So if nothing else has worked, nothing else has relieved the distressing symptoms, we initiate palliative sedation to mild intermediate levels, and that has not brought relief either, then palliative sedation to unconsciousness is used for aggressive symptom-specific palliation. Such symptoms commonly include pain, nausea, vomiting, agitation, delirium, dyspnea, uncontrolled bleeding, and myoclonus or uncontrolled seizures. So as we all know, suffering can be multifaceted. It doesn't have to be physical symptoms or physical findings. Suffering can be emotional, can be psychosocial. Suffering can be emotional, psychosocial, and spiritual. But ultimately, all types of suffering are interrelated, leading to existential suffering. So the question is, can we use palliative sedation for spiritual emotional suffering? Most of the governing bodies do not have any consensus. Most recommend against it at this time. There are no clear guidelines. So in practice, currently we use palliative sedation only for physical symptoms, refractory symptoms, not used currently for emotional or spiritual suffering. So suggested clinical guidelines for initiating palliative sedation: patient must have a terminal illness, death must be imminent, the patient suffers from refractory symptoms, and the clinician perceives that any further intervention is not going to relieve these symptoms. A DNR order needs to be in place, informed consent needs to be obtained, and as mentioned earlier, withdrawal or withholding of any other life-sustaining treatment, nutrition, hydration, ventilator, needs to be addressed prior to sedation and needs a separate consent from palliative sedation. So factors to consider before initiating palliative sedation. The clinical intent. Clinical team's intent is to relieve the suffering, and the 4 conditions of doctrine of double effect need to be satisfied. Patient's intent, which may need spiritual evaluation and psychiatric evaluation. Informed consent, and if needed, an ethics committee evaluation to ensure that the above intents and actions are ethically acceptable. So certain institutions have guidelines in place before initiating palliative sedation, and the suggestions may include psychiatric evaluation, spiritual evaluation, and an ethics consult prior to initiating palliative sedation. So how is palliative sedation different from euthanasia and physician-assisted suicide? So let's look at it in perspective of this case. You are considering palliative sedation for a 56-year-old female who has widely metastatic ovarian cancer. She has refractory nausea, vomiting, pain, and bleeding. The patient and family have agreed for palliative sedation, but the staff brings to your attention that although they have agreed to palliative sedation, they will not accept euthanasia. So how would you explain the difference between euthanasia and palliative sedation? So the key difference is intent. The intent in euthanasia is to hasten death, while the intent in palliative sedation is to relieve intractable suffering and not to hasten death. Sedation is only to the level that would relieve suffering for that patient and family. So certain differences between palliative sedation and euthanasia. The goal in palliative sedation is to reduce suffering, and so is the goal in euthanasia, finally to reduce suffering. But the intent in palliative sedation is to sedate the patient to be able to relieve that suffering, whereas the intent in euthanasia is to cause death. The process or the proportionality in palliative sedation, we use sedative medications that are titrated to a level that would reduce the suffering for the patient. Whereas in euthanasia, it's a lethal dose that would cause death. The outcome in palliative sedation is decreased level of consciousness. Outcome in euthanasia is death. Palliative sedation can be reversible at any point, whereas euthanasia is not. So does palliative sedation affect survival? Does it hasten death? So far, we have no evidence to support that patients who undergo palliative sedation at end of life have a shortened survival. There is no statistical difference in survival from the date of admission between sedated versus non-sedated palliative and hospice patients. So essentially, from the data we have, palliative sedation does not hasten death, does not affect survival. The intent and the goal is to reduce suffering, and doing that, we do not affect patients' overall term survival. Certain definitions from AMA Code of Medical Ethics. Euthanasia is defined as the administration of a lethal agent by another person to a patient for the purpose of relieving the patient's suffering by causing death. Physician-assisted suicide occurs when a physician facilitates patient's death by providing the necessary means or information, such as a prescription, to enable the person to perform the life-ending act. AMA Code defines both of these policies to be fundamentally incompatible with physician's role as a healer. But palliative sedation is legal in all 50 states. So that's the tool that's essentially available across the country to relieve terminal suffering. Physician-assisted suicide is legal in certain states, and the list is increasing every year. We have many new states that are added on recently. Euthanasia is not legal anywhere in the United States. So the medications used in palliative sedation. Most common medications used are Ativan or lorazepam infusion with or without a concomitant morphine infusion, or phenobarbital, which can be initially used as a scheduled dosing and then eventually titrated to an infusion. Other medications that can be used include midazolam, thiopental, methotrexate, and multiple other medications are available, but what we use commonly in hospice and palliative care is lorazepam, morphine, and phenobarbital. Meds need to be titrated to relieve distress, or if mild or intermediate sedation does not relieve distress, then sedation to unconsciousness using the lowest effective doses. Certain barriers to palliative sedation. Hospital and institutional policies. So these policies can be barriers, especially if the policies include mandatory evaluation and consults and ethics committee prior to initiation of palliative sedation. Fear or lack of knowledge on part of the medical team, physicians, and other healthcare professionals. Lack of experience for the palliative care physicians. And fear of legal ramifications due to lack of knowledge. So the last slide for certain pearls on palliative sedation. The use of palliative sedation is derived from the ethical principles of autonomy, informed consent, and the doctrine of double effect. Palliative sedation is only used at the very end of life in the dying patient who has refractory uncontrolled symptoms. The intent of palliative sedation is to relieve suffering, not to hasten death. On the other hand, the intent for euthanasia is to relieve suffering by hastening death. The most common refractory symptoms are pain, dyspnea, nausea, vomiting, and agitated delirium. With that, we end our talk. Thank you.